7th, 2016 Human Services Committee meeting to order. According to the agenda you have on board docs and in front of you, I am looking for an approval of it. We have a motion in support of the agenda as printed. Any comments, questions, corrections, additions, or deletions? Seeing none, all in favor of accepting the agenda as printed?
Aye.
Opposed? We have an agenda. Next up, we have public comments. Is there anyone that would like to address the board? Seeing no one interested in offering their insight to us, we will then move on to the meeting minutes of October 10th.
So move the minutes.
We have a motion and support to accept the October 10th meeting minutes as presented. Any additions, corrections, deletions? Seeing none, all in favor say aye.
Aye.
Opposed? Meeting minutes accepted. Next, we have Lifeway's monthly report. Hello, Mary Beth.
Good afternoon. Yes, it is. All right, well, good afternoon. So you have in front of you this month's report. A couple of things that I'd like to point out that's not on the report is that we're in the middle of our CARF accreditation audit. Begins next week, Monday and Tuesday. So we've been busy planning for that. We just also had our strategic planning summit with our board last week. We have a 3-year plan. We are 1 year into the plan, and we are at 47% completion with that plan, so we're pretty proud of that for a 3-year plan. We did work to make some recommended changes for the remaining 2 years of that plan, and we will be amending that and bringing that to our board in December. The other things that are happening at Lifeway is we're in the middle of preparing for our Lifeway's financial audit that occurs in January of this next year. And we will be submitting an amended budget to our board. We did a draft, and then we did get notice that we received the federal grant through SAMHSA for the $1.6 million, so we will be amending that budget for that purpose, and it will go to our board in December. So I just wanted to kind of give an update about that. The other thing that's included in your packet kind of celebrates the 50th anniversary. We had that happen this past month. We were fortunate that Senator Debbie Stabenow came and she spoke. And she's a very powerful speaker, very committed to mental health, and it was great to have her there and support the direction that the agency is going in. Other thing that I wanted to point out in your packet is related to the work that's occurring at the Association for Direct Care Workers. Through the state and also through legislation, legislators want to have a work group that really focuses on the fact that direct care workers, there's many challenges. And we experience it locally related to the turnover that group homes have related to direct care workers, and that does impact quality of care. A lot of it has to do with the fact of the funding. There has been proposals in the past where they actually did legislation, a direct care wage pass-through, and those dollars were funneled directly to direct care workers. They haven't done that in several years, and there's a lot of advocacy occurring that we need to do that and funnel dollars towards direct care staff, because they can go down the street and make $13 at, Walmart or somewhere else where the wages are higher, and direct care workers have one of the toughest jobs out there. They really do. And we're trying to advocate on behalf of additional funding for direct care workers. The other thing that's included in your packet is letting you know about some mental health block grant activities that we're trying to pursue related to funding. So one of the opportunities that we have is a juvenile diversion mental health block grant, and it would allow us to be able to funnel and use dollars to really divert individuals, youth, prior to ending up in adjudication. The focus of those grant dollars is to work with the schools and the judicial system to prevent them from even being adjudicated. So we've met with key partners in our, with the schools and with probation to talk about how we might be able to do that. So we will be applying for this mental health block grant for juvenile diversion. So I wanted to let you know about that. The other thing that's included in your packet is around work that we've been doing as an organization to really streamline and create efficiencies within our agency and look at those areas, especially in our access area, because people coming to that front door, in the past, we did not have what's called open access. So if you came in and you were in need of services, you would come in, you would see somebody while you were in crisis, they would then ask you to come back for an appointment, and then you would come back and hopefully we would engage you to come back and hopefully you didn't lose that opportunity for engagement. And then after that, then there was another follow-up appointment for when you would schedule that with whether it's a therapist or case management or psychiatrist. So the time that it took for an individual to get into services was quite delayed. We've put into play what's called open access, so it's important for you as county commissioners to be aware of the fact that people can come in today and get their screening and get connected with services today. So that's what open access is about, and we've made that change. And that is it for my report. Are there any questions of any of the county commissioners?
Commissioner Rice?
Mary Beth, in the report here, you have on here, and I understand why you did it, that Section 298 being a threat.
Yes.
But, and maybe you would agree with me, maybe not, but to me that, as you call it, threat actually has jump-started Lifeways in a way that maybe we would not have done before, at least to the capacity that we are now. And just to let the board here know that Lifeways is taking some huge steps and being very assertive in a good way to be a totally integrated system, health from a standpoint of physical, mental, behavioral health, ultimately substance use disorders, et cetera. I mean, so it's going to be it'll be an organization where, generally speaking, anybody at some point, hopefully, I get this right, will be able to walk in the door as opposed to the emergency room and receive help, and that's a key right there. Because the whole idea, of course, was to keep people out of the emergency rooms with the Affordable Care Act. We know now that's not working. But if you have something like an access center that's available to people to walk into and the community gets to know about it, then they're going to be hopefully more likely to walk in there as opposed to go to the emergency room. And that model can work.
Right.
And I'd just like to throw in one other thing. There's also, it's a key performance indicator model that Lifeways, we had a workshop Friday for 5 hours, and we're going the route of what's called a key performance indicator model. And that will track the performance of employees, that'll track financials, it'll track everything to make sure that we are, as Mary Beth said, streamlined and also running efficiently and, quite frankly, using dollars in the best way possible fiscally. So I just wanted to throw that out there that there are a lot of good things happening. They haven't all unfolded yet. Let's just hope that they do.
Right. Right, so when you talk about the key performance indicators, if you've never heard that term before, really what that is putting into play accountability for all staff, from the line staff all the way up to myself, related to these are expectations, related to productivity of staff, that there's so much time that's billable. It really is changing the mindset of how we operate from a business to one so that we can be competitive. You are correct that I've talked about Section 298 here before, and it is a threat. I mean, when you look at the potential that the public system as we know it may not exist. However, as an organization, we're trying to look at it and say, okay, if that is a reality, how can we be a player in that? And really, in order to be a player, you have to be able to demonstrate that your costs are lower than your neighbors. And so we're putting those things into play. Change is difficult, I will tell you that. We have seen some staff turnover as a result of pushing this KPIs down to staff and having some expectations. But that can be expected with change. You either embrace the change and move forward with us, or that's that. So we are hopeful about that, and we do see this has been implemented in other places nationally, and there have been positive outcomes for organizations that have been able to do this, so thank you. Any other questions?
Commissioners? Seeing none, thank you, Mary Beth.
All right, thank you.
Next on the agenda, Richard from the Health Department. We have a presentation on HIV infection rates in the risk population groups in Jackson County and the city of Jackson.
Good afternoon.
Afternoon.
Looks like I have the rest of the afternoon with you, don't I? Well, yeah, I did want to come back. We had talked about this off and on for a few months. Commissioner Mahoney had originally requested some additional detailed information on what HIV infection in the city and the county looked like by some of the demographic variables. So it took us quite a while to pull this data together and then to turn it into information. So we were able to do that, and we're happy to bring it back to you at this point in time. So this is an analysis of the prevalence and incidence of HIV infection by age, gender, and race/ethnicity in Jackson County and the city of Jackson as of December 1st of 2015. So background-wise, quickly, request by Commissioner Mahoney in conjunction with presentation of data from our 2014 annual report about this time last year. And a couple definitions, because it's kind of important to understand the difference between prevalence and incidence, because these are epidemiological terms. So prevalence refers to the total number of people living in a community with a specific disease or condition as of a specific point in time. It's usually expressed as a percent or a rate per 100,000 population. And incidence is the number of new positive persons identified over a specific period of time expressed as a rate per 100,000. So prevalence always includes incidence in a community. So these data that I have on the screen right now exclude persons living in institutional facilities with HIV, such as the state prisons. If we were to include those as part of our community numbers, our rate would be somewhere in about 450 per 100,000, because there's a lot of HIV incidents in our prison population. So they've been excluded for us so we can look just purely at our county from a residential perspective. As of December 1st, there were 189 diagnosed cases of HIV/AIDS in the entire county. 158 of them, or 84% of them, are among residents within the city of Jackson, and 31 or 16% live outside the city in the county. From this point forward in the slide presentation, most slides will show the difference in number, percent, or rates of HIV infection between the city and the county without the city. So you can see the difference within the city and outside. White persons are more likely to be living with HIV than all other racial groups within the community. That's not inconsistent with the population demographics, if you will. But the distribution also is not proportional to the population by racial/ethnic group in the community. For example, black persons represent 8% of our county population, but 33% of all persons living with HIV in the county are African American. So we have a distribution problem here. Numbers are suppressed, just so you're aware, when cases are less than 5. That's why you don't see a number next to the Hispanic group in that particular slide. The distribution of cases on a percentage basis between different racial and ethnic groups is similar to the number of cases by these same racial and ethnic groups. So the numbers and the percents line up pretty closely. On a percentage basis, though, HIV is highest among white persons in our community. The overall prevalence rate of HIV infection per 100,000 population in the city and county combined is 118. But health disparities with respect to HIV infection exist on a geographical, race/ethnicity, and gender basis within the Jackson community. People with HIV infection are 5 times more likely to be residents of the city versus the county. But that doesn't necessarily mean that increases the risk of transmission. People with HIV may choose to reside in the city where they have easier access to health care, the social system, and family support. So there may be legitimate reasons why people live in the city who have HIV versus in the county. But the high density of cases in the city also increases the potential risk for further transmission of HIV infection. The vast majority of persons, this is 158 of 189 cases, living with HIV infection, regardless of race/ethnicity, reside in the city of Jackson. The 31 cases of HIV infection in the county are predominantly among white males. The information in this slide provides a bit of a further breakdown of the residential location of persons living with HIV by race and gender. All black males and most white males and females living with HIV live in the city. The numbers, again, are suppressed when there's less than 5, but you can see what the distribution is between the county and just within the city. The percentage, although the percentage of a number of white persons in the county living with HIV is similar, all black persons, Hispanics, and most people of other race and ethnicities living with HIV do live in the city of Jackson. This is a slide that shows the age distribution, if you will. And the distribution of cases by age is consistent between the city and the county. So although more people with HIV are living in the city from those who have the infection, the age distribution does not differ between the city and the county. When we look at the age distribution in a vertical bar chart, what we have here is a relatively well-defined bell-shaped curve. So the group that's most at risk, I suppose, if you will, for HIV infection, and the people in our community that do have the infection are people, adults aged between 20 to 49. And that's typically also what we see and is consistent with what we see on a statewide basis. So we're no different that way. The primary risk factors or categories in our community among the majority of persons living with HIV in the city and county is males having unprotected sex with males. This is our risk group in the community. It's who we try to target all the time with increased testing and education. And we do actually match these same factors or categories that are seen in the state of Michigan. And this includes, the comparison I'm using here is excluding the Detroit area in southeast Michigan, because we're more like the out area from the city of Detroit than we are in the in-city. So it's pretty consistent. This identifies the proportion of persons living with HIV in outstate Michigan by risk transmission category. So again, these categories seen in outstate Michigan are most applicable to us here in Jackson County. If you're trying to figure out what some of these abbreviations mean, HCM is females who had sex with males, and HCFR is males who had sex with females with known risk. This slide is showing the prevalence rate per 100,000 population broken down by available racial and gender demographic variables within the city and the county. These are the only groups that we actually have the data broken down into, if you will. And overall in the community, based on these variable rates per 100,000 population, individuals living with HIV are 5 times more likely to be black than white, 5 times more likely to be male than female, 5 times more likely to be a black male than a white male, and the prevalence of HIV infection per 100,000 persons is up to 19 times higher in the city of Jackson versus Jackson County without the city. And that's just because the residential location where they're living. But again, the higher prevalence of persons living with HIV in the city does have the potential to increase the risk for further transmission of HIV infection. And this is particularly true and relevant if the people that we have living within the community, particularly within the city with HIV, are not doing a really good job of staying on their medications. If you're staying on your medications, the potential for transmission is really quite low, because the drugs that are used nowadays actually reduce the CD4 cell count way down, and the viral load is really low to the point where it's difficult to actually transmit the disease now. I saw an infographic on the other day on the CDC website that I thought was quite interesting. People living with HIV are now more likely to die from smoking than they are from HIV. So that, if that puts it in perspective for you, that's how much the risk has been decreased. Yet, we have seen transmission taking place in the community. It has primarily been among and between people. In our particular case, what we've seen most recently is actual heterosexual transmission from an infected male to uninfected females. And that is really primarily because of not managing the medication, not being seen by your healthcare provider when you need to. And when that happens, the viral load goes up and the transmission can occur. Some fast facts about HIV in Michigan. The rate of new infections has remained stable between 2008 and 2012. So we're not seeing any kind of meteoric rise. It's just small and incremental. But it does continue to be disproportionately impacting certain racial and ethnic groups. The rates of new diagnoses among black males are 11 times higher than among white males. Rates among black females are 18 times higher than among white females. Black males and females make up 14% of the general population, but in Michigan, 55% of persons living with HIV.
Commissioner Shotwell?
IDU is in some of our slides. And let's see, I can go back here, about 5 slides back? Okay. Or not. Okay. IDU is listed in this particular slide here at 7%. This is overall in the state of Michigan. For us, it is also quite low. Okay, right here in this particular slide, you see that 6% of persons living with HIV infection in Jackson County and 5% within the city had an indication of intravenous drug use as their risk factor. So it is not the predominant mode of transmission here in Jackson County. Yes?
No, with the increase of heroin use.
Well, it's kind of hard to say that I see it increasing now because this data takes about a year to accumulate, and this is only through December of 2015. But if, to the extent that we have had drug abuse occurring in the community with opiates and heroin, if you will, it's not showing up here at this point in time. So that's good news for us. Did I get to your question, Commissioner Shotwell? Okay. So I'll move back forward. So this is kind of where I left off. The risk transmission category with the highest number of new diagnoses, as well as the majority of all prevalent cases, does for us remain, as well as in the state, men who have sex with men. And it's because it's unprotected and whatever risks they have going on with respect to either they haven't been into care. There are some people that we know are positive in Michigan. I mean, the CDC has a model for estimating how many people who have HIV that have not been detected and not tested. And if they haven't been tested and they don't know they have the disease, it's certainly possible to continue to transmit it up until some point in time that their health begins to deteriorate. So continuing to link also people who have HIV with care to make sure that they don't drop out of the system is important as well. So it's an ongoing effort that we make and that all the other organizations in the community who are trying to battle the disease make as well. Persons with a risk of heterosexual sex represent an increasingly larger proportion of new diagnoses. Michigan has begun to investigate state-specific rates of HIV drug resistance and subtype variability. They're beginning to see a little bit of resistance developing in some of the slightly different strains of HIV. And HIV-positive persons who have not been tested, have tested anonymously, or have tested by name but were not reported are not included in state analyses. So people can, for example, come to the health department and receive confidential and anonymous testing. But when they do, their name doesn't get reported into the system, but that is a service that's offered. Yes, sir. We probably don't know.
So we're allowing non-residents at our expense?
And we are required to do so if we accept the funds from the state of Michigan. Yep. This is a map of the state of Michigan. This is the most recent one that I could lay my hands on. And what we're trying to do here is to help us understand how the HIV epidemic affects different areas of Michigan. Local health departments are divided into two groups in this particular map, those above and those below the midpoint rate. The rate of the highest prevalence local health department divided by 2, excluding the city of Detroit, is the midpoint that the state staff have established for counties in Michigan. So as a way to moderate the effect small numbers may have on rates, they're calculating these rates based on local health department jurisdiction. So for example, if a local health department is multi-county, like District Health Department number 10, which has 10 counties, or District Health Department number 2 or 4, whatever it happens to be, it's those multiple counties combined. Because in some of our small, low population counties and rural areas where density is quite sparse, you can't come up with a valid, reliable estimate of a population per 100,000 rate if you're just using an individual county. But that said, the midpoint rate that's been calculated in the state is 93. So therefore, high prevalence local health departments are those at or above a rate of 93 per 100,000, and low prevalence counties are those with a rate below 93 per 100,000. So 15 jurisdictions have rates at or above the midpoint, the dark green on the map, and as you can probably pretty much quickly figure out, this is where the majority of the population is in the state of Michigan, so it's not surprised that we might have higher rates down here. We are at 118, so we are considered to be a higher prevalence community in the state of Michigan. This slide is looking at new HIV cases and prevalence rate per 100,000, if you will, in the county between 2012 and 2015. So the prevalence rate, if you will, or the infection rate that you see in the top line is how our rate has been going since 2012. We didn't have any new cases in 2012. We did in 13 and 14 and 15, and that's what I was referring to previously, is that we have had some transmission take place in our community, and we are concerned about it at the health department. We did see a reduction in the number of new cases in 15 compared to 14, but our rate will continue to slowly increase over time if new cases are added and because people are successfully living with HIV infection long-term.
Does it surprise you in 2012 that it's listed as 0?
Yeah, that is a surprise, but that is what the data show us. And we're not really sure why we had 0 in 2012. We just didn't have any positives. And 13, 14, and 15 have caused us some concerns.
Commissioner Shotwell?
The 2012 anomaly, though, is new cases, correct? We have
That's correct.
Correct, but
Yes, you are correct. You're absolutely correct. Those are new cases, and we didn't have any new cases, but you can see we still have a prevalence rate of 91 in 2012.
Did we change
The
our
pricing.
advertising?
Our advertising as far as the availability of testing,
Yeah, letting people know.
I can't really say that we changed it publicly. In other words, we didn't do a major outreach education effort, but we have been reaching out to other partners in the community to increase testing. And we've been collaborating and doing testing. For instance, we did testing at Walgreens earlier this year. That was the first time we did that.
And I'm reflecting back, thinking we modified the pricing system and mechanism, and it had to have been close to about 3 years ago.
It was as far as fees for the STD clinic
STDs.
visit, but these particular visits are not charged a fee because we're funded by the state to provide the testing and
Okay.
counseling. So that wouldn't affect it.
However, one could have been coming in to be tested for something else and additional test, but, oh.
Yes,
okay.
someone could be coming in for a classic sexually transmitted disease infection, but we're going to evaluate them also for their risk for HIV.
Correct, and/or even a pregnancy test,
Yes,
correct?
absolutely. Yep. So we're trying to be pretty comprehensive about it. So that's what it looks like for us at the moment. So here are some conclusions I would share with you. HIV cases in the county outside the city are more likely to be white and male than those diagnosed in the city, reflecting the population demographics in the county versus the city. Cases in the city are disproportionately more likely to be among African American males and females, and the prevalence per 100,000 person is up to 19 times higher in the city of Jackson versus Jackson County without the city. That's what the slides and the data are telling us. But again, just kind of reiterating that people who are HIV positive or living with AIDS may choose to live in the city because they have much more easy access to health care here through Allegiance Health. And they have other kinds of supports that they may need as well, both from family and socially. Their presence in the city does not necessarily mean that they contracted HIV in the city or even in Jackson County. Because once a person is positive and they move and set up residence here in our community, they will eventually be counted as one of our prevalent cases. So people move around. It also doesn't necessarily mean that because they have chosen to live in the city that they are actively transmitting the virus to others. We haven't found that to be the case. Nevertheless, the fact that we continue to see new HIV infections does suggest that transmission is occurring predominantly among the African American population in the city and is highest in African American males who are having sex with other males. So that is our primary focus that we need to maintain in our community. And you'll see in a couple slides here too that we have some ideas about how we might approach that in the future. Cases in the city are slightly more likely to be diagnosed in younger age groups, 13 to 29, and less likely to be diagnosed in older age groups, 30 to 59. When compared to individuals diagnosed outside the city, this isn't statistically significant in any way. It's just what the data show us. The prevalence data represent both new and previously diagnosed cases among persons living in the county. As new treatments increase the lifespan of people with HIV, the number of persons living with HIV will continue to increase, and this creates the potential for more transmission. And again, we're considered a higher HIV prevalence community at 118 cases per 100,000. What kind of resources do we have in place to address this issue in the community? Well, first, free and anonymous rapid HIV testing and counseling at the health department. It's also available, HIV testing and counseling, through healthcare providers in the community. We work very closely with the infectious disease physicians at Henry Ford Allegiance Health. Strong emphasis on condom use through the health department's STD treatment clinic, along with other services. Periodic outreach testing with community partners at Jackson College, home of New Vision Recovery Center, Walgreens Pharmacy, Born Free, and the Victory Methadone Clinic. So we have worked with all of them to increase testing as much as we have the resources to do every year. The HIV/AIDS Resource Center prevention programming is here in the community, and they have campaigns and delivery of HIV-related healthcare services, access to healthcare and antiviral prescription drugs through enrollment in the Healthy Michigan Plan, third-party health plan coverage, marketplace health plans, and Veterans Administration, and pre-exposure prophylaxis, or PrEP, is a daily pill for people who are at substantial risk of getting it to prevent HIV infection. And Dr. Kack at Henry Ford Allegiance Health does provide this pre-exposure prophylaxis. In most cases, when we're talking about pre-exposure prophylaxis, is related to a partner of a person who is known to be HIV, but they themselves are not positive at this point in time. And it's really done as a preventive measure to prevent them from becoming infected in the first place should something fail. Further prevention and cost reduction is possible. We have talked about potentially expanding mobile outreach units or street outreach to a variety of locations to reach people where they are at, and that is one of the recommendations from the CDC. Engaging more in faith-based initiatives, particularly in our African American communities. Expanding CDC recommended PrEP through Henry Ford Allegiance Health if there's an indication to do so, and although the data don't really support a significant amount of transmission taking place through IV drug use, considering a syringe replacement program expansion. It is available through one location in the community. We do not provide it right now through the health department. That would be something to explore further. So I think my conclusion and bottom line is we're going to continue to seek resources that we can use to address the disparities identified among different population groups in the county and prevent further transmission of HIV in the community. So I'd be happy to answer any other questions you might have about this.
Commissioners? Commissioner Placzek?
Richard, do you have any information on the syringe replacement programs elsewhere to show that they've been successful?
I don't know how successful they've been here in Jackson County, but what I do know is that it was implemented rather significantly as a result of the huge upsurge in HIV transmission cases that took place in southern Indiana about 1.5 to 2 years ago. The Indiana governor actually wrote an emergency order to authorize, I think it was both needle and syringe replacement, and I think that in combination with a lot of other health education and prevention messaging in southern Indiana did really help to get that under control in that community. So they can be effective. I think to some extent it depends on how much of a problem are you dealing with. Yes, sir.
Commissioner Mahoney?
First of all, thank you very much for the information. Very, very detailed. I appreciate it a lot. One question that I would have, and I'm not sure if you would have any specific information on this, would be with the increase in among black females and black males, is there any conversations being had with some of the ladies that come in there about, kind of being careful about men who may be sleeping with men as well as women, because it kind of seems like that might be
Yes.
what the issue is.
And that is part of the full risk assessment that's done for anyone coming to our STD clinic, is all of those kinds of questions are asked and probed to help the client understand the risk factors that may be placing themselves at. We do that.
All right, seeing no other questions? All right, again, and thank you for that presentation. Next on the agenda, with the third amendment to the original agreement coming due to expire here in a month, we are looking for an approval of the fourth amendment in order to send to the full board, allowing our county administrator to sign the contract between Henry Ford Allegiance Health and Jackson County to maintain those services. We have a motion and support to move it to the full board. Is there any conversation, comments, questions?
Yes. Yeah, it's been very successful.
So we have a motion and support on the table. Seeing no other comments or questions, all in favor? Opposed? All right, this will move on to the full board. Next on the agenda, we have the Health Department contract agreement with the Michigan Department of Environmental Quality. Richard, is there anything specific you'd like to address on this contract?
Just a quick note that this is our standard contractual agreement on an annual basis with the Michigan Department of Environmental Quality for specifically quite a few environmental health programs. The only thing I would point out is that from year to year, there's a little bit of an increase or a decrease. I think in this particular case, it's about $2,500 or $2,600 less than it was the previous year. And some of that is simply related to changes in programs. For instance, the Type 2 non-community water supply program was ramping up for an additional requirement last year, and that has now been taken care of and has been implemented, so there's no need for that continued funding. So that's really the only change that's in this agreement.
All right, as we're looking at the documentation, so the contract is under $50,000 for the 1 year. It is $48,343,000, correct?
Correct.
All right. Well, with that information presented to us, then this contract could be approved by Human Services. I'm looking for a motion to make that approval. And we have motion support to make that approval of that agreement. Any comments, questions, concerns? Seeing none, all in favor say aye. Opposed? Motion passed unanimously, or unanimously with those present at least. Next on the agenda, we have the Health Department agreement with McLaurin Health Plan. We have we're looking for authorization to enter this agreement for 1 year, beginning here next week, with subsequent automatic renewal. Richard, is there anything you'd like to add and address regarding this health plan?
We have an existing contract with McLaren Health Plan now for being able to bill them for immunization and lead testing and communicable disease or other kinds of services we provide at the health department. This is a specific agreement with McLaren that allows us to be recognized as a maternal infant health program provider. As I've previously mentioned in past meetings over the past few months, this is another one of those 6 contracts, if you will, or agreements that we have to enter into in order to continue to maintain our ability to bill for these services to the plans. And this is McLaren's, and it's pretty straightforward, standard boilerplate content. It's been reviewed by legal counsel, and I would encourage your approval for us.
Commissioner Placzek?
If I read correctly, did you put this out for bid and you had 5 people respond? Something like that? Did I read that?
We wouldn't have put this out for bid. This is a requirement being driven by the Michigan Department of Health and Human Services.
Okay.
They're requiring the plans to contract with us.
Must have read somewhere else something. Okay, thanks.
Okay, yeah. Oh. No, well, there are 6 plans present in the county selected by MDHHS. So we have to contract with each one of them. So sorry if I created some confusion there.
All right, seeing no other comments or questions regarding this contract, I am looking for a motion to send this to the full board to authorize this agreement.
So moved.
We have a motion and support via arm wrestling down there to send this to the full board. Comments or questions? Seeing none, all in favor say aye.
Aye.
Opposed? All right, this will move forward to the full board.
Thank you.
You are welcome. Health Department Monthly Report. Richard?
Yeah, I'll touch on a few things in my monthly report that's in board docs. We did have a typical quarterly call-down drill on September 22nd, and I think the particular thing to point out here is that what we're finding from drill to drill is that the most efficient way for us to reach staff for purposes of call-down and communication back to us on their availability, if you will, is by text message. I never thought I'd be standing up here telling you that, but that is what we are experiencing at 81%. So that, I think it's just an indication of how much technology is at play and in use on our daily basis now. There's a Zika virus update in my report as well. As of probably earlier this week, we have had a total of 3 pregnant women in the state identified as having the Zika virus infection. There have been no in utero adverse health effects identified to date in those 3 pregnant women. None of them are residents of Jackson County, in case you were wondering about that. So it continues to be a concern. We heard something in a Zika virus call teleconference with the state recently that the Ontario province is actually investigating the possibility of having found the Aedes aegypti mosquito in their community. And that is the primary vector for Zika virus that we've seen in Florida and lots of other parts of the Caribbean and South America. They think it's possible, though, that the mosquito that they trapped and collected may have actually been imported through possibly even shipping containers coming from some of these other areas where the disease is endemic. So you always have to kind of check it out. We did complete our accreditation review during the week of October 17th through the 21st. It was a very good visit with a very good outcome. The results are identified here in my report. We had what we consider to be two very minor deficiencies, if you will, that were noted in the Children's Special Health Care Program, two indicators that were identified as not met, and they are all simply documentation and timeliness of submission of reports related requirements. Those have already been corrected, so there's really no issue there, and we will be accredited again for 3 years very quickly. Let's see, what else do I have here? There's an update under Henry Ford Legion's Health, under Health Integration. There are some committees that are forming now up at the state level, and one of those is a non-clinical care committee, which I've been encouraged to consider joining, and I will do that when that opens up in 2017. Otherwise, they're all pretty clinically focused, either in advanced payment model studies or in clinical care delivery, if you will. And I don't usually get involved in those particular types of committees, but the other one would be very appropriate. The Financial Stability Network continues to move forward in the community. They have now identified an executive committee for that coordinating council, and the policies and procedures have been finalized, and I've been asked to sit on the executive committee and have agreed to do so. Immunization clinic hours are now 9 a.m. to 4 p.m. I may have mentioned that last month, but that was as a result of our construction project where we have pulled our key nursing staff together all in one location now to serve both the STD clinic and the immunization clinic, and that's actually allowed us to increase our hours excuse me, from 9 a.m. to 4 p.m.
Mr. Shetlow?
Yes, we do have one clinic per month on a Wednesday that runs until 7 p.m., and it's co-located and timed with the WIC clinic as well. So that was what we have the resources to do right now. So yes, there is a late date. Yep. Influenza is present in our community as well as elsewhere in the state. We had a influenza B rapid antigen test diagnosed in a child that was admitted to Henry Ford Legion's Health on October 12th, so we know it's here. And then there were some influenza A tests that were identified through the State Bureau of Laboratories, I believe, in southeast Michigan. So I hope everybody got your flu shot. If not, I'll be bringing a nurse next time to take care of you right here. It's been a busy October. We had 2 advisories take place during the week of October 17th. The first was a 4-page health alert network message from the CDC, which provided the latest guidance for pregnant women and men of reproductive age for Zika virus infection that was shared broadly with our medical staffs in the community through Henry Ford Legion's Health. And the second advisory was released to Henry Ford Legion's Health on the subject of confirmed measles case with a potential exposure of 250 people on the Ann Arbor campus. We've not heard anything more about that. We've not seen any persons in Jackson County identified or diagnosed with measles, so I think we're probably fine. We're probably well beyond the normal incubation period for that disease, so I don't think we'll be seeing any measles cases pop up in our community. I did want to mention, though, you may be aware, you may have seen something in the media, one way or another. There has been a nationwide, multi-state investigation of an outbreak of hepatitis A associated with frozen strawberries imported from Egypt. Staff and I have been busy over the past weekend and Thursday and Friday of last week, actually investigating whether any facilities, institutions, food service establishments in Jackson County received any of the lots of the potentially contaminated strawberries. We have lucked out, if you will, in that while some facilities were on the list as potentially receiving them, they had received information from the distributor here in the state. There's only been one distributor that's been distributing these particular strawberries, and they had not used them, or they had already been recalled, so they were not served here in Jackson County. So we don't have to worry about hepatitis A cases associated with frozen strawberries in our community.
So freezing The product does not
Not
kill
kill the
the
virus.
virus.
Correct. Yep. You'd like to think so, but that's not the first case or first instance of contaminated strawberries that we have dealt with in Michigan. This happened about 10, 15 years ago as well. Started in
about-
Calhoun County.
What about heating or cooking or boiling the strawberries?
If they are heated, baked, cooked above a certain temperature, yes, you will kill the virus and you won't contract it that way. But these frozen strawberries are often taken right out of the package, served on shortcake, excuse me, put in tropical smoothies, which is the transmission source when they first identified it in other states. And so when it's not cooked and it's raw product, that's where the biggest potential is for transmission. So I think there's a few other updates here that I probably don't need to go into in too much detail. I think you can see what we were talking about with the Jackson Traffic Safety Program funding. We did see a 38% decrease in the grant amount requested. We have since communicated back with the Safety Commission on what we'll be able to do with those resources, and they have accepted our proposals, our revised proposals for doing so. So that's pretty much my report today, and I'd be happy to answer any other questions anyone has.
Not only is it your report today, you are our Human Services meeting today. Thank you, Richard. We
Happy to
appreciate
be of
all
service.
the insight. Anyone have any comments or questions for Richard? Again, thank you for all the detailed information. You
You're
make
very
us
welcome.
much more knowledgeable. Been passed around the committee were the claims from 2016. Would anyone like to entertain a motion of paying those claims? We have a motion in support. All in favor say aye. Opposed? We also have meeting minutes under a separate category with nothing to report, which leads us to the December reporting schedule. In December, our final Human Services Committee meeting of the year, we hope to hear from DHHS, Department on Aging, Health Department, Lifeways, Medical Care Facility, and Veterans Affairs. That leads us next to public comment. Is there anyone that would like to address the board? Seeing no public comment at this time, that leads us to committee member comments. Are there any committee members that would like to address the board? Commissioner Placzek.
Richard, you bring in the vaccine, I'll give them the shots. I've oversaw 6,000 so far this year. And for everyone that has a competitive race tomorrow, good luck.
Absolutely. Let's all remember to vote on tomorrow, November 8th. Seeing any other committee member comments? Seeing none, at 12:53, we will adjourn to the call of the chair.